Hello, good evening. I'm Michelle Battye and I'm the manager of the European reference network called EUROGEN, which deals with rare urorectogenital diseases and complex conditions. So just before we get started, I'd like to take a couple of minutes to tell you a little bit about what ERNs are and what they do. So EUROGEN is one of 24 European reference networks created and funded by the European Commission in 2017. And we are currently a network of 56 healthcare providers in 20 member states. And the aim of the network really is to deliver quicker specialist evaluation and more equitable access to high quality diagnosis, treatment and care for patients with rare urorectogenital diseases and complex conditions. So these are all patients that need highly specialised surgery where the expertise is rare. So some of the activities we do, well, I hope you noticed from the slides at the beginning, we conduct virtual cross-border consultations. So our experts can provide advice on how to treat these really complex patients. And we welcome any requests for advice from any healthcare professional working in any country in the EU. So please feel free to get in touch. We also collaborate together on training activities like this educational webinar programme. We work with scientific societies producing clinical guidelines. And another very exciting area is we're rolling out the EUROGEN patient registry. This one of the main problems for patients with rare diseases is the lack of data. It's fragmented and it's scattered across all different countries. So we really want to bring that together in one place. And of course, that'll be very, very useful for the evidence for the clinical guidelines and also for future research projects. So without further ado, this is part of our colorectal series, and tonight's webinar is about anorectal malformations and paediatric anaesthesia. It is CME accredited, and it's kindly supported by the ARMNet, EUPSA, and another ERN, Ernica. And the presenters this evening are Dr. Stefania Franzini, and she's from the Hopital Universitaire, Necker Enfants Malades, and that's APHP in Paris, France. And she's a paediatric anaesthesia expert. And she's going to talk about anaesthetic considerations for children undergoing surgical repair of anorectal malformations. And again, it's another honour for us to have here tonight Professor Ignacio Malagon, and he is from the Amalia Children's Hospital in Radboudumc University Medical Centre in the Netherlands, and he's a consultant in paediatric anaesthesia. And his talk is about the neurotoxicity of anaesthesia and regional anaesthesia in paediatric anaesthesia. So we're incredibly grateful to both of you this evening for sharing your expertise with us. And I give you, Stefania, the floor. Thank you.
Good afternoon. It's an honor to be part of this conference today. My name is Stefania Franzini. I'm a pediatric anesthetist and I work at Nijmegen Enfants Malades Hospital in Paris. I have no conflict of interest. Early in 2024, the ERN consortium published a 10-year review, which includes data on almost 2,700 patients enrolled over 30 years in 34 European centers. From this data, we recognize that our patients are often burdened with associated malformations which require additional consideration by the anesthetist. Defects can include skeletal, cardiac, renal anomalies, and so on, and the defects can be major or minor. In fact, multiple anomalies may coexist in the same patient. As we know, anorectal malformation can be classified into high or low forms according to the position of the rectal pouch in relation to the elevator ani plate. Low forms occur in a minority of patients and may be treated by primary repair in the first days of life. On the contrary, high forms occur more often and usually require the staged procedure within the first year of life. Our study showed that associated anomalies may influence the timing of reconstructive surgery, as patients with associated malformation are older at reconstruction than patients without. In addition, surgery can vary from the simplest to the most complex reconstructive procedure. Patient position can vary too according to the type of repair, which can be challenging for the anesthetist. Position can range from supine to prone, often with the head-down tilt. Furthermore, a changing position is occasionally required by the surgeon during surgery. Surgery may also be marred by complication in up to 25% of cases, requiring further access to theater, sometimes as urgent cases. Thus, it's clear that we are dealing with a complex population that often undergo extended and sometimes repeated surgery under general anesthesia in a physiological position during the very early stages of their life. There is a lot for the anesthetist to think about. When we prepare an patient for surgery, we need to consider the presence of other anomalies, patient factors, and the surgical position. In neonates, a preoperative workup is mandatory to rule out a cardiac malformation which may require early surgical correction. In addition, spine anomalies might prevent from the use of regional anesthesia. We usually deal with neonates, which represent a high-risk fragile population. They are occasionally premature and may have a lower weight. Later on, we will discuss the surgical position. In this recent paper, Christian Koenen described the impact of surgery and anesthesia during early brain development. This is a diagram of the processes which govern early brain development from neural tube formation until 1 year of life. The processes involving neurogenesis are depicted in green. Events that result in neural connection formation are in blue. Removal of neural connection are in red. As we can see, most of ERN patients undergo repeated surgery, while synaptogenesis, myelination, and removal of connection are still in progress. The second part of this paper is dedicated to factors potentially involved in brain injury. Here, Koenen proposed a novel disease model of prolonged exposure to anesthetic drugs that comprises a triad of neurotoxicity, inflammation, and vascular immaturity. And she postulates that the intensity of inflammation may depend on length and number of anesthetic procedures. So, whenever possible, the number and duration of surgery should be restricted. Of note, the neonatal brain has immature vascularization and impaired autoregulation, which the anesthetist can play a role in managing. Autoregulation is the ability of the brain to maintain stable oxygenation and perfusion in the face of any changes in mean arterial blood pressure. This ability in neonates can be altered by hypotension, prematurity, general anesthesia, inotrope drugs, and surgery. Each of these elements need to be addressed by the anesthetist. This paper was published in 2014, and for the anesthetist is a milestone. It described a case series of 6 neonates undergoing extended surgery for more than 2 hours addressing the effects of inappropriate anesthetic management conducting using just standard monitoring. Convulsions were observed in all patients 24-48 hours after anesthesia. 50% of patients faced severe neurological outcomes. Chart review showed evidence of repeated episodes of hypotension and hypocarbia despite the standard monitoring. Its message is that standard monitoring as such does not prevent brain injury to neonates. Besides severe anatomical lesion, minor injuries may occur affecting functional domains. These papers suggest extended exposure to general anesthesia or repeated exposure to general anesthesia may affect behavioral outcome in children. This recent meta-analysis published by JAMA shows that children exposed to general anesthesia present more behavioral problems, more deficit in executive function, nonverbal reasoning, and motor function than unexposed children. So, as an anesthetist, is there something that we can do to protect our tiny patient? In this paper, McCann described 5 intraoperative factors potentially affecting cerebral perfusion in neonates and claims for better monitoring of cerebral perfusion as standard monitoring alone appear to be inadequate. And concludes that alongside standard monitoring, including blood sugar, we need to monitor cerebral perfusion to better protect the brain. And for doing this, we can use NIRS monitoring, which employs non-invasive infrared lights to measure the amount of oxygen available at tissue level, which can be used to estimate the balance between oxygen delivery and oxygen consumption, as more and more evidence from pediatric cardiac anesthesia suggests that the cerebral desaturation detected by NIRS are linked to poor neurological outcome. In fact, multi-site NIRS may also be useful. These NIRS traces belong to an outpatient undergoing PSARP in Milan in 2017, allowing to monitor the cerebral in yellow, the renal in blue, and the mesenteric perfusion in green during surgery. However, it's important that if additional monitoring is used, it should be properly understood and applied by the anesthetist. This study shows that despite the use of NIRS, early postoperative behavioral changes may occur following just minor episodes of intraoperative cerebral desaturation up to 20%. This recent study shows that early postoperative behavioral changes in children are multifactorial. Factors involved include not just intraoperative cerebral desaturation as seen in the previous paper, but also preoperative anxiety and postoperative pain. Furthermore, some suggest that our patients carry a greater risk of attention deficit hyperactivity and autism spectrum disorder not explained by concomitant clinical conditions. However, the proportion of outpatient undergoing neonatal surgery is higher than in the control population. This sketch summarizes factors that potentially affect outcomes in patients undergoing early exposure to general anesthesia. As you can see, it's quite complex, but it's important to realize that as an anesthetist, we are unable to control or influence all these elements. However, we can improve the intraoperative management by using the Safe Thoughts quality checklist, which defines 10 minimal requirements for conducting safe anesthesia in children proposed by a panel of experts in 2017. And perhaps in the future, our regular monitoring will look more like this, with expansion of the standard monitoring to include bispectral monitoring to measure the depth of anesthesia, NIRS monitoring, and maybe one day the null monitoring, which quantifies physiological pain response, whose validation in children is still in progress. Before I finish, I want to talk to you about another important consideration, the chosen position during reconstructive surgery when patients are often prone with the head down tilt. These are the potential risks of this position in neonates, which can be more than just pressure injuries. We can have peripheral nerve injury, increased intra-abdominal pressure, and obstruction to cerebral venous outflow, which can lead to cerebral desaturation. Here are some adverse hemodynamic effects in which can occur in even short-term prone positioning in neonates. We have in particular reduced cardiac output and increased systemic vascular resistance index with no positional change in the heart rate. And these are the potential respiratory drawbacks of the prone position. In 2020, we performed a study in Milan aiming to answer the question, is prone position and head down tilt well tolerated by the child undergoing EBSARP? We implemented a fixed ventilation protocol, and we showed that surgery in this position can be safe and well tolerated for up to 3 hours. And so the take-home messages. Most patients with anorectal malformation undergo repeated lengthy surgery, often in a natural position as neonates and infants. General anesthesia in childhood is associated with neurobehavioral disorder, and the origins seem to be multifactorial, including preoperative anxiety, depth of anesthesia, intraoperative cerebral desaturations, postoperative pain, and as well as length of hospitalization, family and external environment. Optimization of all the above factors is crucial to improve patient safety and reduce complication of general anesthesia in this population. While multicenter, ample, stratified core study with longitudinal observations are needed to confirm these findings, it's clear that our patients are complex patients worthy of additional consideration by the anesthetist. Thank you very much for your attention.
Thank you for the invitation and the opportunity to actually discuss this matter, which is obviously very close to all pediatric anesthetists. I don't think that we have a silver bullet that can actually solve the problem. My conflicts of interest is I have very few conflicts and even less interests. And I always like to quote Lord Balfour, who was the Prime Minister for a short period of time, longer than a lettuce. And he's remembered by this quote, which is that nothing matters very much and few things matter at all. I'm hoping that at the end of the next 20 minutes, you will not feel this way at all. So for those of you who are in a hurry, I would like to start with the conclusions, which is that the evidence of neurotoxicity related to exposure to anesthetic agents in animal studies is uncontroversial and robust. Unfortunately, the primary endpoints in clinical studies are influenced by covariates and confounding factors. Most of the studies will use IQ or the presence or the prevalence of ADHD or other behavioral changes. There are few clinical prospective studies. Altogether, put together, is about 800 patients. And there is no overwhelming evidence that regional anesthesia is better. And therefore, we are left with common sense, which for those who are French would be delighted to know that the sentence or the quote, common sense, comes from Voltaire. And actually, common sense is not particularly common. So if we're talking about common sense, I also like to quote the famous sentence from the Supreme Court Justice Potter in the 1960s. And he basically said, I know it when I see it. And he was referring to a court case that went up to the Supreme Court relating to pornography. What's the definition of pornography? Now, I think that if we turn the clock back 80 years, we could actually say that common sense is like pornography. We find it difficult to define, but we recognize it when we see it. So our problem starts in 2016. This is the following 2017, but in 2016, the FDA issued a warning about the use of general anesthetics and sedation drugs, not only propofol and sevoflurane, but also extended to the likes of midazolam, in young children and pregnant women. Now, I would like to remind the people who are listening to or watching this webinar that more than 2 million children under the age of 5 undergo general anesthesia or sedation in the US alone every year. So my contention is that if these drugs were deleterious to the patients, then I think that we would have been confronted with some sort of public health problem a long time ago. So I'm not trying to make it look easy. I'm just saying that there are so many things that we have to consider here, and I will take care of some of them over the next 20 minutes. Now, history tends to repeat itself if we forget it. And for those of you who are old enough to remember the 1990s, there was a paper which basically was a Cochrane review published in the BMJ in 1998, basically said that albumin not only does not save lives, but may increase mortality. Now, I can assure you that as a young senior registrar looking after children with meningococcal sepsis, when I went after the third or the fourth bolus of crystalloids, I went for the albumin. Some parents would look at us, not only me, but all the colleagues, and said, what is it that you're going to use? I said, well, this is albumin. I said, well, the Times magazine says, the newspaper says that albumin kills. Now, we fast forward another 20-something years, and then you can see that this is a surviving sepsis campaign, international guidelines for septic shock in children. And I'll just summarize it for you, but basically after nearly 30 years of research, we cannot say more than, well, albumin, if you don't have it, don't use it. If you have it, use it carefully. And there's actually not much difference between using crystalloids or colloids or albumin in this case in terms of mortality. So we had to wait 30 odd years to actually come up with a solution or the conclusion that, in fact, albumin is not just that it doesn't kill, it's just that it's expensive and might bring some of the problems with it. So you obviously have to use common sense when you use it. Now, protein is yet another drug that went through the problems of the Spanish Inquisition. It used to be a fantastic drug. Then suddenly the family Mangano decided that after an extensive and well-conducted prospective observational study that included thousands of patients undergoing cardiac surgery, the FDA had no option but to actually issue a warning about the use of protein in cardiac surgery because it increased the risk of renal failure and mortality itself. Now, we're now through 20 years of having put the label of protein as a bad guy. Then it was assessed subsequently following very emotional and protracted prospective randomized trials. Where we ended up is that protein is now back on the shelf, and it is a fantastic drug. And yes, you've got to be extremely careful because in some circumstances will actually increase the risk of renal failure. So this is 2002, and this is the original paper that actually showed apoptosis in very immature rats when being exposed to general anesthetic agents. And you can see you don't have to be a brain surgeon to actually see that there's a lot of dead cells there. So this is what started the whole problem. Now, the problem now is that when we try to translate these studies in animals into humans, then we end up with a major problem, which are the primary endpoints that we're going to use. And we go to in IQ or ADHD, behavioral changes, and these are mostly self-reported. So therefore, you've got to take them with a pinch of salt. Now, what many of the colleagues that actually set up all these studies in the past didn't realize, or perhaps were not aware of, is that there are other things that can actually induce ADHD. So therefore, you've got here a meta-analysis from 2021 that basically exposure to paracetamol intrautero, and that is when the pregnant woman is actually taking paracetamol during the pregnancy, actually increases the chances of ADHD more than 20%. Now, that meta-analysis has been repeated and included 70,000 patients, and the results were very similar, and that is that. So exposure to paracetamol during pregnancy increases your chances of having a child with autism spectrum 20% and more than 20% ADHD. It's more common in boys, and there is no damage if that paracetamol is taken after delivery. Now, yet another massive meta-analysis, systematic review and meta-analysis of the use of paracetamol in the intrautero, or at least during pregnancy. Now, this one included 22 studies, more than 360,000 patients, and basically confirms previous findings. And the indication for the paracetamol is not a confounding factor, actually didn't have any impact whatsoever. So we know about paracetamol now, but there are other culprits out there that perhaps have been either forgotten or not taken into consideration seriously. And there are a number of toxic chemicals which we are exposing ourselves and our offsprings to that actually have potential implications to the liver, exactly the same outcome than the exposure to anesthetics, and that is potential reduce of IQ, behavioral changes, increased incidence of ADHD. So there are more than 200 in this review, more than 212 studies, and then 74 studies reported in association with racial, ethnic minorities, and low-income children, which is disproportionately harmed when exposed to these toxics or these pesticides. Now, the authors of one of the original papers looking at the neurotoxicity related to general anesthesia or anesthetic agents, they did try to correct for ethnic minorities and social background and income. However, one of the authors eventually admitted or agreed that that was not completely watertight. So therefore, they opened the door to actually include these are covariates or variables that might influence the outcome, the results. So you got air pollutants, lead, mercury, organophosphate, pesticides. All these are primary endpoints found in cognitive, behavioral, and psychological changes. And again, race, ethnic minorities, and poverty play an enormous role. So far, if I can summarize, we are all focused on general anesthesia. However, there are a number of things going on out there that actually might influence the outcome that we think is directly related to the exposure, i.e. pesticides, other toxic agents, and paracetamol, who would say that it has to be blamed for something. Again, this is another review where basically looked at the residential exposure to some pesticides. And I will go a little bit further into it, because before I do that, some of the culprits is lead, and you would have thought that, and you would be forgiven for thinking, Jesus, lead. We are in the 21st century. Who is going to be poisoned by lead or increased dose of lead in the water supply? And here we have it. This is from March this year. Nearly 130,000 children were exposed to increased, considered unhealthy concentrations of lead in drinking water in the Chicago area. So what about, we talked about paracetamol. I would like to dwell a little bit in the prenatal exposure to organophosphate pesticides. Now, these are studies that have been going on now for many years. One of them actually happened, and I'll show you another. This is the Chamacos cohort study. These are women living in the California area, San Jose Valley, and are being exposed to pesticides. And all these researchers, what we're trying to figure out is that, is the exposure to pesticides during pregnancy has an impact or an influence in the presence of ADHD and IQ and the rest? And the answer is yes. So we do have now a long list of elements or drugs or chemical compounds that actually can deliver exactly the same endpoints than the exposure to general anesthetics. And indeed, in this systematic review, 66 studies covering virtually nearly 30 years, including also anesthetics, but also cadmium, lead, mercury, organophosphates. So anesthetics play a role. However, we must not neglect or discard the impact of other elements, of other poisons, and producing exactly the same results. Now, this is one of the original papers that basically looked at the impact of anesthesia in children younger than 3 years of age, and the impact in the presence of IQ changes, behavioral changes, and the rest. And again, this another paper basically confirmed the findings, and you can see that the numbers are quite massive, so you cannot neglect that. These are the 3 papers that have been mentioned many, many times: PANDA, MASK, and GAS study. The GAS study basically looked at the use of either regional anesthesia, i.e. spinal, versus general anesthetic, i.e. sevoflurane, to do inguinal hernia repairs. And basically, they didn't find any differences whatsoever. So one short exposure does not confirms that does not have an impact. Now, the other study that I thought quite interesting was this one, the association between a single general anesthetic exposure in children, in siblings. So this is very interesting. If you actually go and read the inclusion criteria and the protocol, there is an immediate bias. In order to understand the protocol, you've got to be an intelligent person. So therefore, there is a bias towards people who are actually have got a higher IQ or a higher social ability, or are more competent in these matters. And that means that siblings that were exposed to either anesthesia or not didn't show any difference whatsoever. This is a reminder, once again, of what I already mentioned before about the poverty as a risk factor in these areas. Now, so someone actually had the time and the energy to actually put together in a meta-analysis all the studies that actually have looked at this particular matter. Now, no more than 800 patients, single exposure, parents report abnormal behavior, but there's no change in general intelligence. So therefore, 800 patients compared to 2.5 million children being anesthetized every year in the US basically tells you that the chances are that giving anesthetic is not that bad. Again, for those of you who have problems sleeping at night, here are 2 beautiful review papers that I advise you to actually, not advise you, but I recommend you to read. Now, we wanted to make our own contribution to this matter, and we did do again a meta-analysis and systematic review of all the non-clinical, i.e. animal studies that have been published, where the exposure to halogenated ethers, okay, so no propofol, no midazolam, and we looked at what sort of results did they find in the long term. Now, I'm not going to bore you with this, but I'll give you the summary and the short version of the whole thing, and that is that unfortunately I have bad news for you. And the overwhelming evidence is that the exposure to halogenated ethers in animals in the long term alters behavior, and it is reproducible. And we looked at all the different methods to actually reproduce and assess changes in behavior in these animals. So I think we did a reasonable work on that. And again, this is just another histogram to actually show you that indeed, if you don't have the time to read the paper, there are statistically significant changes. So we know that there is a short-term change. There is also a long-term cognitive and behavioral changes following exposure to general anesthesia. So the question that we have to ask ourselves is, what else can we do about it? Is there anything new? And unfortunately, the new anesthetic agents that might come into the market or already in the market, if we go through the list, remimazolam does not have EMA approval, European Medicines Agency, or FDA approval to be used in children. So we're using remimazolam off-label. Now, we as pediatric anesthetists are very keen to actually make sure that we stick to the rules and we protect children. And of course, we do that with the best intentions in the world. However, here we have yet another example of a drug that has not been tested in children and is being used in children. So when we go ahead to actually conduct studies looking at IQ, behavioral change, and the rest, the first question that we need to ask ourselves is, where is the evidence that this drug is safe in properly well-conducted, prospective, randomized trials with all sorts of the fancy pharmacokinetic and pharmacodynamic studies? So there are unanswered questions of anesthesia and neurotoxicity in the developing brain, And if I can summarize it in 3 points, is that there are ethical issues. We cannot do an MRI scan after surgery just to make sure that we know exactly what the brain looks like. And definitely we cannot take biopsies. It's completely unethical. Now, IQ, behavior are subjective to the assessment and to the experience of the parents. And unfortunately, there are no physiological markers. So I would like to leave behind this first part of the presentation and now go into the next part, which is, okay, so we know that there is something going on. There is some music there. Is there anything that we can do to reduce the exposure to the anesthetic agents? Is there anything that might save the bacon at the end of the day? Well, again, for those of you who have difficulties sleeping at night, this is a fantastic review, and I mean it. Yeah, I'm not kidding. This is a fantastic review about the use of epidural and spinal anesthesia for newborn surgery. After you read this paper, you will know a hell of a lot about this stuff. And indeed, if you look at the box number 1, if you look down to the bottom of the box, you will see may reduce or eliminate risk of anesthesia-induced neurotoxicity. So the authors already assume that that neurotoxicity is directly related to the exposure of anesthetic agents and not something else. And again, there is no free meal in this world. So a regional anesthesia, i.e. in this case, epidural for neonates, comes with risks, and I think we're all familiar with those risks. And if someone who is not an anesthetist listening or watching this webinar, there is, I mean, obviously all these things happen hardly ever, but there are reports and it can happen. So therefore we have to mention it, or at least take it into consideration when making a decision about what we're going to use. Now, this is a pro-con debate, the use of regional versus systemic analgesia for neonatal surgery. If you look at the slide, you will note this goes back to 2011. So we are 13 years further down the line, and we're still not being able, I'm just jumping the gun, but we are not able to actually come up with a definitive answer about what is better. Is better to give a spinal or an epidural, or just to stick to a multimodal cocktail of opioids and non-steroidals? And indeed, if you go through the literature, you will find that the results are just a little bit either disappointing or a full-blown disaster for those who actually want to convince themselves that regional anesthesia is better than intravenous opioids, or a cocktail combining some of them. And again, this is a Cochrane review, which basically comes to show that, yes, there are some benefits, but that definitive answer to what we all seek. I mean, I'm the first one to actually would like to be able to actually tell the parents, I'm going to offer this to your child, and this is the best option, instead of saying, well, I think this is better, and we know that for some things it's better. Once again, go back to this Cochrane review, but this is not 100% certain. And indeed, if you we skipped that element, we skipped that particular question, fundamental hypothesis of comparing epidurals with regional anesthesia with intravenous opioids. and we move forward to actually compare it with other things. So here we have a meta-analysis comparing anavertebral block with other things. Again, rather disappointing. I've just put on a box the editor's key points, and you can see that yes, paravertebral block has a very important role, in particularly in thoracic surgery. There are certain institutions in the UK that do not put epidurals anymore for lung surgery. They do paravertebral blocks plus epipleural plus a multimodal analgesia, avoiding all the usual problems of epidural, i.e. urinary catheters and having to put central lines to control blood pressure and the rest. So there is a larger randomized trials are needed to confirm or refute these findings. Again, a bit disappointing. So, you know, I'm saving you the time to actually read this stuff. And then you can see indeed in the table that the comparisons are all over the place, you know, so you compare paravertebral block with epidurals, with local anesthetics, and so on and so forth. And the operations are available. So we know that paravertebral blocks are good and might be even better than epidurals in some surgeries. What about TAB blocks, transversus abdominis plain block? Extremely simple block to do. You go nowadays with the ultrasound, it is a fantastic thing to do. And there are certainly, I would argue that there are certain types of surgery where nothing else is needed but a good TAB block. And yet, in this systematic review and meta-analysis, the conclusions are that there is moderate evidence that TAB blocks and epidural analgesia are equally effective. So therefore, you've got to sit down with the surgeon and think carefully about the extent of the surgery, what are the chances of actually increasing the depth, going intraperitoneally, and so on and so forth, to actually decide to go for either a TAB block or an epidural. And again, it's not that it's not bad. Indeed, some of the studies actually, and don't forget, if you look at, I don't know if you can see the mouse, but and these are number of studies, but there's only 2 pediatric studies, and one of them basically is very close to the 0, which means that it doesn't favor either TAB block or epidural analgesia. So can we say anything about comparing another form of epidural or limited epidural, which you could call the choral block, and ileoinguinal or ileohypogastric block? And again, this is a fantastic prospective randomized trial with limited number of patients, which basically demonstrated that there is no difference, that actually ileoinguinal blocks are as good as a choral. So when you have to make a decision, and this is something that I take a lot of responsibility about this. When we talk to parents about it, I always leave the door open. I said, look, I'm not the one that is going to give the anesthetics, so there is a choice to be made with 2 techniques, and I'll leave it up to the team on the date to decide and convince the parents that basically both techniques are safe. So here we are again, epidural versus PCA after pectus excavatum repair, and here you can see that yet again there is disappointment in the sense that you would hope that the epidural is going to show an uncontroversial, overwhelming, better performance than a PCA, but that is not the case. And yet again, another example of and this can be quite controversial sometimes. It's a limited study, only 45 children, but when you look at the comparison, this group actually compare non-epidural methods with epidural for this particular plastic and operation, and they found no difference whatsoever. So in conclusion, and I'm sorry that I went a little bit off the time, and in conclusion, once again, for those who actually fell asleep or came back from a cup of tea, and there is evidence, the evidence is uncontroversial in animal studies. We cannot, there's no point in discussing it. There is demonstrated effect, deleterious adverse effect of exposure in immature brains to general anesthesia. However, the primary endpoints in clinical studies are influenced by other things, which we cannot control some of them. So therefore, when we eventually come to the final decision to say, together with the surgical team, what are we going to do here for this particular patient? Again, Voltaire has to come to the forth and say, let's use some common sense. Thank you very much indeed.
Yes, thank you very much. I shall put on my webcam as well. Yeah, hi. Great. Thank you both for the interesting presentations. We will wait a couple of minutes for people to type in their questions if they have any. Right now, there hasn't been any questions coming through, but just a reminder to the attendees, you can type in your questions somewhere. I think down below you can find a chat or a Q&A section, so feel free to type in. In the meantime, I would like to mention that the webinar has been recorded. So tomorrow we will send the recording to everybody who registered for the webinar via email to enter our, I believe, EUROGEN Zoom Hub. That's the new thing instead of GoToWebinar, which we used before. And we will also put it on YouTube. So follow our YouTube channel so you can all see our past webinars on there as well. Yeah, in the meantime, there are no questions here I can see. You can also type in your question in the, I believe, survey. We will send out a survey afterwards. So the webinar is also, like Michelle mentioned at the beginning, EACME accredited. So everybody who fills in the survey immediately after the webinar has finished will get a certificate after 2 weeks. So please do fill in the survey so we can continuously improve our sessions. So yeah, if there are no any questions anymore, you can always email me as well, so I can pass the questions through to the presenters. But if there aren't any questions, then I would like to thank you, the presenters, for the interesting presentations. I really enjoyed it. It was very nice to watch with the jokes and the common sense. So thank you very much. And I wish you all a very nice evening.
Thank you very much indeed. Thank you. Okay. Yes, take care. Cheers.
Bye.
Bye-bye.
Thank you very much.